Next, we're going to have a video presentation and some comments on the consumer perspective. Larry Minnix, who's a member of the forum, is the president and CEO of Leading Age, and with him is Dr. Alwan, Senior Vice President of Technology and Executive Director of the Leading Age Center for Aging Services. Larry?
Yes, thank you very much. And it's my role in this to move us from where Dr. Fernie is introduced these concepts into looking at some real-world situations in which some of this technology is already available and being applied. Leading Age is made up of 6,000 not-for-profit service providers throughout the country. A great example of which will be, you'll hear from Steve Sailing, who's a resident of the Leonard Florence Center that is part of what is known as the Chelsea Jewish Nursing Home in Massachusetts. They're over 100 years old, and their CEO, Barry Berman, along with Steve Sailing, whom you'll meet, is an architect. They have designed an environment for people with ALS, MS, as well as seniors. And they've developed it around the greenhouse model, which is another example of technology, architectural technology, as well as culture change technology. So you're going to see with Steve Sailing's presentation how a number of technologies are integrated into a program. Steve is a remarkable individual, one of the most inspiring people I've been around in a long time. If you visit his apartment, you'll find out he is an Auburn fan, and those of us that like Southeastern Conference football, I told Steve that we remember when Auburn used to have a football team, so he may want to comment on that. I told him he gets the last word. And then Dr. Maj Alwan, who's director of our Center for Aging Services Technology, chaired by Mark McClellan, is going to debut a video under Dr. McClellan and Maj's leadership. We wanted to get the word out that technology in aging services is available today to improve quality of life. It's relatively inexpensive. It's there. How do we broadly apply it? So you'll hear two different presentations, beginning with Maj's today coming through an aging door and a younger people with disability door, but it gets down to the very practical. Without further ado, it is my privilege to introduce Dr. Maj Alwan, followed by Mr. Steve Sailing.
Thank you, Larry. Good morning, everyone. And Larry forgot to mention that I have a background in engineering, but I assure everyone in the room that I have repented and converted. So, well, to being more closer to the users, closer to the caregivers and the provider organizations. So CAST, for those of you who are not familiar with CAST, is a program of Leading Age that brings together over 400 pioneering aging service providers together with technology companies from the big all the way to the small startup companies, as well as researchers from universities. And our mission is to expedite the process of developing, validating, evaluating, and the adoption of appropriate technologies. Again, we serve the over 6,000 leading aging service providers who are in turn serving over 4 million seniors on a daily basis. Some of the strategic fronts that we have focused on, that we all need to focus on, we believe, include research at different levels, from research that is aimed at identifying available technologies, identifying their value propositions, and identifying the barriers to their development and adoption. As we've heard from Jeff, it's not easy to translate some of these technologies under development, all the way to development of products using a user-centered design approach that takes into account not only the needs of the end users, but also their requirements and their preferences, all the way to conducting evaluations of these technologies, not in research laboratories, but rather in living laboratories in the provider organizations who are serving these individuals. We also need to advocate for these, to remove the barriers to the adoption of these technologies, both at the federal, state, as well as the local level. Again, Jeff mentioned the difficulty of changing the building code. We also need to work on standards for interoperability and interconnectivity to ensure that these technologies are capable of integrating together, are capable of exchanging data to ensure the continuity of information and the continuity of care when used by multiple care provider organizations and where they're handling transitions of care. We also need to focus on education, starting with educating professionals and educating professional caregivers. Back in 2005, CAST has produced a vision video entitled Imagine the Future of Aging for the White House Conference on Aging. And at the time, the first video that we produced focused primarily on the physician and the family caregiver and the caregiver network created by the family caregivers, and portrayed a number of technologies from mHealth to automatic stoves that shut off automatically and so on and so forth. But the problem was that these technologies were merely on the drawing boards, were either at the conceptual design or as prototypes in research labs, and some of them did not actually make it to market. However, the vast majority of these technologies are now on the market. So what we've done more recently is try to identify models of care that are conducive of the adoption of these technologies. With the passage of the Healthcare Reform Bill earlier in 2011, we conducted strategic scenario planning and identified 3 buckets of care models that are not necessarily new or not necessarily mutually exclusive, but that could become mainstream and are conducive of the use of technologies, as I mentioned. And we also identified enabling technologies under each one of these buckets. The first one, as you can see, is integrated coordinated healthcare delivery. And the program of all-inclusive care, for those of you who are familiar with the PACE program, is a precursor to such models. And under health reform, accountable care organizations, bundling of payments, person-centered medical homes, and so on and so forth, are the new reincarnations, so to speak, of these models. The other model is community-based support services like home care and home health, but enabled by technology so that services are delivered on an as-needed basis as well as compared to a schedule. And finally, the real estate-based model where technologies are used on the campus to improve efficiencies, but at the same time, they can also be used to leverage the campus capabilities to deliver services outside the walls of the campus. And if we look at the common technology platforms across all 3 models or model buckets, there are interoperable electronic health records that are capable of exchanging health information. We have remote patient monitoring and telehealth to manage chronic conditions and stabilize newly discharged patients and encourage self-management. We have care coordination tools that allow shared care planning and care coordination across provider care settings. Later in the second half of 2011, Dr. Mark McClellan, who is the CAST chair, challenged us to identify pioneering organizations among the leading age membership who are actually implementing and integrating these technologies into operational models. So we've collected over 18 case studies about providers who are implementing innovative technology-enabled care models. These models ranged from private pay, virtual CCRC at home or continuing care retirement at home model that is leveraging the resources of a campus and delivering services into the wider community. There's also examples of partnerships between hospitals and long-term and post-acute care providers around hospital readmission reduction. There are retail outlets, providers who are taking out and creating retail outlets and going out directly to consumers to serve their needs. And there are technologies like virtual senior centers who are enabled a senior center to deliver its services to homebound individuals in the heart of New York. Earlier this year, we have completed a report for the Department of Health and Human Services, the Office of the Assistant Secretary for Planning and Evaluation, entitled the Aging Services Technologies Study, in partnership with the National Opinion Research Center at the University of Chicago, Newark. And the report, I'm mentioning it because it really provides an excellent framework. We systematically looked at 8 care issues, from falls to chronic disease management to medication management to functional decline, all the way to depression. And we looked at the value or the evidence of efficacy and cost effectiveness of technologies, different technologies for each one of these care issues. We also had, the report also had a chapter that's dedicated to the barriers of development, use, and adoption of these types of technologies. And we also dedicated the chapter also included strategies that could be used to overcome these barriers. The report reaffirmed why the adoption is slow because of some of the barriers that you're all familiar with, including lack of awareness, not only among the consumers, but more importantly, among professional caregivers, physicians, discharge planners, and so on and so forth, who are considered trusted referral channels for these types of technologies. Technical issues related to usability, competency in using computers and technology on the user's side, and also interoperability and so on and so forth. One of the major findings in the report is that the variability of evidence. Some technologies had strong evidence of efficacy. Others had less evidence. Some were proven to be cost effective. But the issue of cost effectiveness is really related to the operational and business model that these technologies are used into. For example, remote patient monitoring and telehealth has the strongest evidence of efficacy and cost effectiveness, but the majority of the evidence that we've seen came from the Veterans Administration studies, which is unique and not really generalizable. So in our opinion, the biggest barrier to the adoption of these technologies is actually absence of business models that are conducive, that have alignment of incentive, that are conducive for the adoption of these types of technologies. So how can we overcome these barriers? There are a number of strategies that were discussed in the Aging Services Technologies report. I don't have enough time to go through some of these, but we firmly believe that strategic partnerships between acute care and post-acute and long-term services and support providers is key to getting some of these technologies widely adopted. And this is exactly why we decided to produce this video, which shows coordinated care. And if we can play the video. In this video, we tried to focus on technologies that are commercially available today, that are actually in use by provider organizations, but on a smaller scale and not in an integrative manner, the way it's portrayed in the video.
My name is Alwan Jones. I've been living here in my apartment for 20 years. I love it. I have some great friends. I do what I want, when I want. My great-granddaughter, Gabrielle, she's the light of my life. My goodness. I teach her how to bake, and she teaches me how to Google. And now it's me, my daughter, my granddaughter, and her daughter. We're 4 generations strong. I'm so proud. I have my aches and pains for sure, but I never thought I'd live on my own in my 80s. When I was a home health nurse, we used to see patients for a 30-minute session, and then they were on their own. or sent to a nursing home. But look at me. I'm making my own coffee in my own kitchen.
Speaking back home, I hate seeing my mom get old. But I think what impresses me most about her aging is that she's taken charge of it. She's had electronic records of her medical history and her current medications created, so we don't have to sift through a lot of paperwork. She had to get a new doctor once, right? You always have to get all the old history and give it to the new doctor. Well, we didn't have to worry about all that. She had everything on. Mom? 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 Where's my phone? Oh, Danielle, bring me my phone! I think Grandma had a stroke.
Hello, ladies. How are you?
So.
Hi. Feel a little bit better than when you got here? Alma's stroke has left her weak on her right side, and she's having difficulty walking. Again? Because Alma's in a care network, we had her entire electronic medical record when she arrived. We knew her conditions, medications, and allergies. It helped pinpoint the right treatment for her stroke. We even knew what medications she took last and when from her medication adherence record. It probably saved her life. Our goal is a plan that gets Alma back to normal, living at home and avoiding a rehospitalization. Here he is. This is David. He's going to get you set up with rehab.
Thank you.
You take care.
Thank you.
Hi.
Hi, David.
You're all set. Your primary care doctor and the rehab center, they have all your information. And I hear they're holding a room facing the garden for you.
Oh, that's so nice. Y'all move fast. Back in my day, a patient would show up with a 6-inch thick folder in their lap, and it wouldn't be till then that rehab people could start their work.
Well, let me grab that wheelchair for you, okay?
Thank you so much.
Sure.
We received Alma's records from Dr. Rodriguez and activated a care plan for her. It monitors and reports her progress to everyone in the network.
Okay, Alma, we're going to start another session. Remember what to do, right?
Mm-hmm.
The physical therapy regimen will have her home soon. Once she's there, her care plan consists of 3 components. 1, telehealth. Alma's doctors will be able to monitor her remotely. 2, in-home sensors to detect if she's declining or needs assistance. And 3, a sleep monitor. This really helps us detect problems early. Oh, in addition, Alma will have a personal emergency response system that can automatically detect falls. These systems help alert her caregivers right away. This really is the future of aging.
I think it's time for you to take an appointment. Dr. Mann, let me get him for you.
Let's look, it's Dr. Lyne.
Hi, Alma. Hey, Suzanne. How you feeling, Alma?
I'm happy to be home, but I'm a little tired. And my arthritis is acting up, and it's keeping me awake. Can we try naproxen for it?
Yes, I see from your monitoring data that your sleep has been disrupted. I wish I could give you naproxen for your arthritis, but I see here they started you on a blood thinner in the hospital. Unfortunately, blood thinners and naproxen are a dangerous combination. The system red flagged me when I entered the prescription. Also, I'd like to start you on more physical therapy. Your home health agency transferred over your motion data from your home monitor, and you should be moving a lot more than you are. What do you think of that?
Oh, that sounds great. There's one other thing bothering me, and I just want to say I hate relying on Suzanne for so much. I keep telling her to take that vacation she's been planning.
Mom.
You know, Suzanne, you should go on that vacation. You can log in remotely to check on your mom as many times as you like. And the home care agency will be there for her.
Well, doctor, I think I'll take you up on that.
Having the time of my life. Wish you were here. Miss you and love you, Mom. Suzanne. It's a miracle sitting here with you, with my plants and my great-granddaughter. I never imagined the way my care team, the doctors, the hospital, my rehab center, the home care agency, how they all communicate with each other so they can give me better care. All this technology made the impossible possible. Now I'm not afraid to be alone. I'm not afraid at all.
Hoping that this movie will stimulate strategic partnerships between and better coordinated care between long-term and post-acute care providers, as well as hospitals, physician groups, and other acute care providers. Of course, we're very grateful to the organizations who supported this video and made this video possible. So here are some important immediate opportunities. Again, the Aging Services Technologies Study report reaffirmed the potential of some of the initiatives under the healthcare reform bill, and including accountable care organizations and so on. But the most immediate one that we see for long-term and post-acute care is primarily focused around hospital readmission. And now that we have the results of the Aging Services Technologies report, we know which technologies work, which don't, which have potential for cost effectiveness, and which have less evidence. I believe that we need national demonstrations of innovative care models that are either led by long-term and post-acute care or significantly emphasizes the role that these long-term and post-acute care providers play. And these are the settings where the 360 days where the patient is not in the hospital, and the 22 hours when they're not in the physician's office. So with this, I would like to thank you all for your attention, and again, thank the forum, and I'd be happy to take any questions while we get Steve to connect his computer.
Thank you very much. Well, Steve is here, and it'll just take us a minute to get his unit connected to our unit so we can view his video. And while we're doing that, if there are questions for Ahmed or for Larry. Yes, Margaret.
Thank you, Dr. Alwan, for your presentation. Just interested in whether any of the membership of CAST or of Leading Edge represented by naturally occurring retirement communities.
Of
People
course.
are not living in facilities, but living in their own neighborhoods where your technology and your services are, with enabling technologies, are supporting delivery of services and coordination of care to them.
Absolutely. A number of our members include the villages, the village people, as Larry calls them, and they include housing providers and naturally occurring retirement communities. Absolutely, and we have one of those actually represented here in the room.
Tracy, let me know when we're good to go. Steve, thank you very much for joining us. We're very grateful for you coming all this way. We're running a bit behind, but we have some room in the schedule to catch up before noon, so we'll be fine. But what we'll do is after Steve's video, we'll go to a break. So it'll be about 15 minutes or so, I think, once we get started.
If there are no questions, a little color commentary. The organization where Steve lives, the CEO, Barry Berman, came in contact with Steve rather serendipitously, and Steve helped to plan the architectural kind of structure of the technology from the inside out. And Barry Berman has a question. He asked Steve and other residents who live in this vertical greenhouse. He asks them regularly, are we doing everything we possibly can to make sure that you are living a maximum independent life? And the answer to that is yes, and they're doing their job. But the answer to that is no. They look at what they can do next. They were able to take all of their residents to Disney World. Most went by planes. One or two had to go by van. Steve skis, skydives, and so if you begin to think about breaking the boundaries of some of our own limitations of how life can be led like that, then Steve is a living example of it. But it's a great place to visit. You can see how the and they like for visitors to come by. I think Alan has been. But our friends at Phillips have been. We're all trying to get to the point that technology can be a reality around helping us all live as independently as we possibly can. But it's quite an inspiring story, as well as Steve being an inspiring individual. I met one of his colleagues that produced a movie, and he can only communicate with his eyes. Yep, we're ready?
No, we're not. If I could jump in, we're going to take a 10-minute break now so that we can set up the technology that we're going to need for Steve's presentation. So it's we'll reconvene around 6 or 7 minutes after 10 o'clock, and then we'll have Steve's presentation and video and go right into the next session. Thank you.